Okay, so we're just going to talk here about our patient assessment. Now, admittedly, this is kind of coming through the lens of perhaps people that haven't been in EMT class in a while, perhaps people that are coming from different departments, or different institutions entirely. Maybe people that knew patient assessment but don't know that I say pain inquiry and dyspnea inquiry. But truth be told, even if every single one of my students had literally taken their EMT practical yesterday, we'd still do this because there's nothing on here that we don't all need to hear a time or two, myself included. Additionally, it's not the same practical that you ran, both conceptually and literally. It's changed somewhat. And so what we're looking at here specifically is essentially, this is a one-size-fits-all solution to a thing that cannot be one-size-fits-all, right? Even when the National Registry ran a practical, they ran it in 2 sheets. One was medical and one was trauma. And they just were like, okay, we can't blend both things. I'm trying, right? So now that, I think, isn't a fine message for AEMTs. It can become a little bit more difficult. So we'll just go line by line here and hit things as they have changed. Of course, when you go in, one of the best things that you can do with your adjuncts is do the job perhaps they should do, which is just kind of managing the expectations. It's the same thing when you're an AMT, you're working on a truck, your paramedic should say, hey, look, here's kind of what I hope today. I may be the paramedic, but I don't sign your checks, which means I'm not your boss. You control the truck and where it goes, which means I'm not going to yell at you when you take a sharp turn. I would appreciate if you were conscientious of me, but more than anything, you are keeping us safe up there. I'm keeping them safe back there. You do your job, I'll do mine, right? Now, I value your opinion as an AEMT, even though I'm a medic. Essentially, whoever has the best right idea, that's what we'll do every time, okay? So if you ever have a better idea, we'll do that. Most of them will be mine. I have dark rim glasses and I've been doing this job a long time, but if a janitor walks in and says, you think that's ACS? If he's right, I'm gonna follow it down, right? Now, I run through a patient assessment. This is me still kind of role-playing, talking to an AEMT partner. Look, I'm pretty specific about my patient assessment. So every patient that we get needs a full set of vital signs, and almost everybody's going to get a 12 lead. So if you want to interrupt me to do that stuff, please do. Just don't interrupt my assessment, right? You want to put him on the vitals while I talk to him, that's fine. But if in the middle of me saying like, hey sir, how's your breathing? Does it feel normal? And you're like, are you a Pisces? I'll be like, what is happening, right? So don't interrupt that part, but I do value your input. I do want you to interact with people. And quite frankly, if you can do a full patient assessment, I won't say a word to them. I'll let you do it all. I don't care, right? It's whoever can win. Now, with the adjuncts, you know, if you've ever run a scenario, the idea is you'll go in and you'll be like, okay, student, let's say Ralph is like, doing a patient assessment and he starts to stumble, he loses his place, and you're like, I could fix this for him. Am I supposed to do that or just kind of watch them flounder? I don't really know. One of the best things you can do before starting a scenario is just ask the adjunct what they want. You know, I try to do it when you run my labs. I'll say, okay, look, we're going to run this like a scenario. Who's the primary? Oh, it's Henry. Fantastic. Who's his partner? Okay, so basically we're going to run this like a practical, meaning I'm going to follow a graded sheet and then give you feedback at the end, except for you can play. Both people can play, right? In a practical, you couldn't. You two, however, are kind of silent. So I'll give you the expectations, you know. A lot of adjuncts won't know to kind of communicate in that way. They're fantastic paramedics and firemen, but maybe communication isn't their strongest of suits. So you can help them with that by just simply walking into the scenario and saying, what do you want from all of us? Do you want me to run this real? Do you want me to run this practical? What do you want me to do? Now, in looking at this, let's assume that we're talking about a graded practical. You'll, generally speaking, have 20 minutes. We'll start with a resource check. And this is just our adjuncts kind of looking at you closely, maybe too closely in some ways, and essentially going through all of it and making sure you have it. Yeah.
For the timers now for our actual practicals, is it 10 or still 12 minutes on scene?
Your scene time will still be 12 minutes. Okay. It's 10 minutes, but since time warps during the ABCs, essentially that's where that 2 minutes comes from. So we only punish you at 12 minutes, but truthfully it's because it's assuming that 10 minutes is happening. Okay. So when we go into the resource check, we're gonna look for intervention cards and ask him to show them to us to make sure that's all they are. It's the intervention cards. Every single practical, at least one person loses points for not having them, which is wild. So make sure you have them. They're a good way of kind of catching you through some issues. Additionally, down the hall is some dude with intervention cards. You ought to go get them before you start, even if for some reason you didn't bring them on practical day, for the love of everything. Okay. Now we make sure you have an empty notepad to make sure that you're not kind of sharing notes about the scenario, and also because taking notes is super important because you just can't remember it all. We'll make sure that you're in uniform, which includes a watch, and by handbook, technically it requires a stethoscope, but personally, since my mannequins don't have lungs, I don't need a working stethoscope, and you're free to use mine. But you'll probably want one sooner than later. As far as pre-plan is interesting. We'll give you dispatch info, something like, you'd be responding to 123 Sesame Street for chest pain. All I'm looking for students to do is just let me know that they are thinking appropriately about what's about to happen, right? If a good chest pain pre-plan would just be something like, well, he said chest pain, I suppose it could be heart or lung, maybe it's not even medical, maybe he fell and that's what hurt his chest. I'm ready to begin. It doesn't have to be super long drawn out. You don't have to reinvent the wheel. I don't mind if you do, but there's a reason why we don't start a timer until after you finish a pre-plan, because some people go down the rabbit hole. And so essentially I just say, hey, give a quick pre-plan. Less is more in many cases. I just got to make sure that we don't get dispatched to chest pain and you're like, chest pain, that's like traction splint stuff plus UTI. And I'm like, okay, we're in trouble. This is about to be a ride, right? Now, when we go into scene size up, we're going to say, okay, I'm going to start my timer and we're going to go through things, and we'll expect you to be literally doing everything and saying everything. That's the best thing you can do. Do it and say it. We'll record it so we can watch it and hear it if necessary. When you wear gloves, if you walk in and say, well, I'd want to put on some gloves and wear a mask, then you ought put on gloves and wear a mask, because if you don't, they don't count. So you want to really do those things. For things like scene safety, it wouldn't be wrong to walk in and be like, well, my scene appears safe. That is a true statement, but it doesn't mean that the scene is safe. It's always better to ask questions than it is to make statements. So I walk in and say, is my scene safe? If I got a tough adjunct that says, as you find it, which I assure you, no one hates that phrase more than I do. But if you walk in and say, hey, is my scene safe? Ideally, they're just going to tell you the truth. Yes or no, it isn't. If I'm trying to teach a lesson, maybe I'll say, well, how would you know? And now you know you got a tough adjunct and you kind of have to play. But moreover, you want to ask these things. Where this starts to really matter is when you make statements that are wrong. An adjunct won't correct you. But if you ask them, they have to tell you the truth, right? So if you walk in and you say, well, obviously this is my only patient. It's the only one I see. I'll say, okay, except for there's a baby tucked under here or whatever. So, but if you ask me, is this my only patient? I either have to tell you the truth or give you an ambiguous answer that probably hints at you looking harder, right? So make sure you're asking questions. If you are insistent on making statements or it's a habit you can't break, then just get in the habit of adding questions to your statement, i.e., oh, well, my patient's airway appears patent. Is that true, right? Like you throw a question on it even if you made a statement. So we go through these things, scene safety, number of patients, consider additional help. This might be somewhat of a change depending on how you kind of landed on this. Basically, we have two locations where we're talking about other people. Now, firstly, you're in an AEMT class, you are ALS, right? So you're not asking for ALS, you're asking for paramedics, if anything. Now, it's true, you don't have some paramedic meds in scope, but you got a lot. You got cardiac and cardiovascular medications, you got the ability to do advanced airways as well as intravenous and all kinds of different things, right? So you are ALS. From a teacher perspective in student world, if it's okay to operate like if they had paramedics and fire available, they'd have sent them. But based on the dispatch info, and since in student world dispatchers are basically perfect, that will never be a problem for you. I just want to hear that you're considering it. Things like, oh, I got dispatch for chest pain. Okay, I'll probably need to call for a paramedic and I'll call for fire perhaps if I need some help moving them. We'll figure it out when we get there, right? It might be like, oh, we're going to Kennesaw Mountain. Maybe I need a Stokes basket. Let's go ahead and get fire. Now, you're not going to be like marked down really for calling them right there if you're right. But mostly what was happening is people would interpret that as considering and then never revisit the idea ever again. Most people didn't do that. So I've added a place on there where I'm like, okay, I know you considered it, now you call, okay? And we call essentially after we've made some determinations on the ABCs. Now, as we move into the primary assessment, what we're talking about is general impression. And like I said before, you really want to ask for a general impression. And sometimes the adjuncts are trying to teach you stuff by saying as you find it, but again, nobody hates it more than me. Because stuff that'll happen, and you'll have a mannequin here on the floor, and you'll walk in and be like, what's my general impression? And they'll say, well, it's as you find it. And you're like, oh, okay, so it's a shirtless, one-hand piece of plastic that isn't breathing, doesn't have a pulse, that's sitting under fluorescent lights, surrounded with a heater that doesn't work, and a bunch of mannequins at is that how, because that is what I'm finding. And they're like, well, no, most of that's not what's happening. I'm like, okay, so then what? Anyways, it irritates me too. But the point is this, is that some of the adjuncts are doing that on purpose for a reason to teach and stuff, but it would behoove you essentially to kind of be asking those questions. Like, okay, my guy's missing a hand. Is that part of it? Okay, he's also got EKG stickers all over him. Is that part of it? You know? So asking is probably your best way through it. Now, one thing that I forgot to add in haste, and though as I'm looking at it, I suppose I can right now, is you'll notice on the right side we have obvious life threats, and then down a little bit more we have apparent life threats. One thing that I'm adding right now is hidden life threats next to expose and assess. Actually, I wrote hidden. That's Arabic. Okay, so we've got basically 3 points in our primary where I want you to walk into walls saying, wait a second, should I be intervening right now? And one of those happens across the room. I walk in, do I have any obvious life threats? Are they on fire? Are they spraying blood? Are they being attacked by a venomous duck? Like whatever the case is, do I need to intervene right now? No? Okay, well, I'm not out of the woods yet. Now I'm looking for apparent life threats and hidden life threats. And they probably got them, or else why the heck am I running this scenario, right? So the first one is obvious life threats. Go ahead.
So what's the difference between apparent and obvious?
I don't expect you to say the words apparent. It's more of like a framework of thinking. Yeah. What I'm really trying to get in, I might as well have just said number 1 life threats, number 2 life threats, and number 3. Okay. But to answer your question specifically, it's because there are some life threats I can see without doing anything. There are some I will only see as I get closer and start looking at your chest rise and fall. And then there's also some where I'm going to have to start exposing your clothing and stuff just to see what is going on. And those are your hidden ones, the ones you're laying on your back and stuff.
So it's like you first walk in, life threats, instant, immediate.
Yep.
And then it's like ABC life threat, and then like the
rapid life threats.
Okay.
Yes, sir. Yeah, it's just, basically what kept happening is I'd watch people go in and be like, ooh, no life threats? I'm chilling. I'm like, no, why do you think I built this scenario? Easy on the chillin'. Like something is somewhere. It may not be in the lower of part of his back bullet hole or whatever, but something in here is wrong. And so I'm trying to get your framework around, okay, here are 3 dead giveaway places where stuff should be happening. Be real sure that you didn't need to do something during that time. So as we go through general impression and obvious life threats, we move into level of consciousness. You'll note that there's extra P there. That's not just because we're a class that's a huge fan of extra P. It's mostly just because I'm trying to get into people. What would happen is this. Somebody would come up and they'd say, hey, I'm going to do a quick assessment. Does my patient track me as I come in? No? Okay, well, maybe they're alert to verbal. Hey, sir, can you hear me? No response? Okay, now I'm just going to do a painful stimuli by lightly tapping on his head, Or they'd be like brushing his arm and be like, I'm going to do painful stimuli. And in a practical, I'm like, that's not painful. That didn't work. Yeah, and so all I mostly mean to say is I don't care that there's not really 2 P's in AVPU. I'm just trying to say there's a distinction between pressure and touching and pain. So if your person is so obtunded that only pain is eliciting a response, then you better be doing pain or else you're going to miss it, right? Do you like that callback?
The phys test?
No, obtunded. Yeah.
I knew I saw it on the phys test, but I'm like, I don't remember it.
I asked King and he kind of just told me what it was.
Okay, so we're moving through, let's see, level of consciousness, greeting and introductions, patient's name and age, these kind of things. I want you greeting and introducing yourself and your partner on every call for every type of patient. And if you said, well, wait a second, what if it's a baby? What if it's a corpse? What if it's whatever? I'm like, I know what I said. Greet them and introduce them. There is not a call I ever ran where I didn't introduce myself and my partner to somebody. And every call. Every second medic has a story about a guy that was completely out of it or unconscious or dead and then came back to life or conscious and knew every word that was said about them, right? So all I mean to say is talk like they can hear you, Additionally, it does something when you don't objectify your patients. When you're like, if your mom fell down, you wouldn't be like, well, they're a piece of meat now. Like, well, depending on your relationship with your mom, that's not ideal, and then probably not what's happening. So I come up to some guy that's in cardiac arrest, I'm gonna be like, hey sir, look, we got you. My name is Mr. Farron, this is my partner John. We're gonna take care of you today, okay? We're just moving around, and I mean, maybe you're getting strange looks because the guy's obviously in cardiac arrest, but it does something to humanize them, even if they're in cardiac arrest. Also, it's important if they're a pediatric and don't even speak English yet. Talking to their parents is important. Talking to bystanders is important. There is no scenario where you shouldn't be greeting yourself. Now, I'm not saying that you should be neglecting patient care while you run around for someone to greet or whatever. That's not what I'm saying, but make sure that you're doing that. Additionally, patient name and age. You can get this accurate information from the patient sometimes. Sometimes you can get accurate information from bystanders like parents or people that knew them. But in any case, you should be looking for it. We're patting down pockets, looking for IDs, phones that can be activated by pulling their eyes back and putting it in the face sensor. And then I scroll down to look for M. Who am I looking for in M? Mom, right? I had a patient once that didn't have that, had about 4 different mommies in there, which was not the kind of contact that would help him. I did write the numbers down, but we had to find some other way of kind of identifying the patient. It was a whole thing. In any event, it becomes a major logistical hurdle at the hospital if you don't have the name and age. Now, you can't always get it. I go out and there's, a homeless fella, or at least somebody in between residences who gets hit by a car and they don't have an ID on them and no one else is around. That nurse is still gonna run me the riot act for not getting a name and a birthday because of what an administrative nightmare it is for them. When they're not able to enter the patient into the system, then they can't associate any previous medical history. They can't tell any family member that's there to see them who that is or where they are. If the police are there and need to involve themselves, they can't associate. There's a million different things that come into play. So we should be trying to get that information, and we need to get in the habit of looking for IDs. What I'm not saying is your hypoventilatory patient, you're like wandering through the couches looking for his wallet and stuff. I mean, pat down his pockets, whatever.
What about like if they give you a false name?
Sometimes they will. I've had plenty of people give me false names because they're trying to dodge different things. But, mostly I'm just trying to get them associated with paperwork. It's both good in EMS for your PCRs because doctors will run studies on your PCRs, but they don't need their names for that so much as they need ages.
I was going to say you don't want to include the name.
In your PCRs, you'll include a name because the PCR belongs to you as much as it belongs to the patient.
But
Just not for clinicals.
That's what I was.
Oh, okay, not for clinicals, sure. Okay, and so when we go through these things, we're doing it every time. Now, C-spine precautions here or consideration that appears just before chief complaint, make sure you note that doesn't mean full C-spine immobilization. This is our manual inline moment. This is my guy's unconscious. I need to go ahead and hold his head stable while I check out what's going on. I do expect you to ask chief complaint, pain inquiry, and dyspnea inquiry for each person. This essentially is just an open-ended question and then 2 close-ended questions. This is a series of subjective questions. Essentially what happens is I'll walk up and say, hey, what seems to be the problem today, sir? And the guy will say, I don't feel good. And I'm like, okay, well, that was a profoundly unhelpful answer, but I can save us both a lot of time. Are you hurting anywhere? And he's like, yeah, my knee. And I'm like, cool, anywhere else? And he's like, yeah, also my chest. It feels like when I had a heart attack. And I'm like, cool, let's talk about that one. So we're going to want to ask that. Where this becomes difficult is for patients that chief complaint was pain. Like they're like, are you hurting any, or sorry, how do you feel today, sir? And they're like, oh, my chest is hurting. And you're like, great. Are you hurting anywhere? Like students struggle with that. I still want you to ask. It just means pain anywhere else.
Yeah, that's how I understand it.
You might say, well, yeah, but what if it's a baby that can't communicate? Or what if it's a corpse? I'm like, I still want you to ask. Maybe a bystander, right? Maybe a parent. Like, oh, okay, so you were with him today. Was he complaining of any pain today? No. Oh yeah, he was the worst headache of his life. Okay, that was helpful. Thank you for that. They don't know what to say. We got to know what to ask them. The difficulty breathing one, admittedly, if they say difficulty breathing, I might ask, is this normal for you? What makes it better or worse? I might start doing sample stuff. That one admittedly is awkward if they say difficulty breathing, but it's so important to me to ingrain in you that you ask it every time that I'm willing to accept that sometimes it's a little weird, right? So make sure you're asking as much as you can. We'll move into the ABCs here. Patency is the first one for airway. Again, make sure you're asking this. Now, I don't list points for inspecting the airway, but sometimes they belong right there, right? I put this primarily in the physical assessment as we go down, but it might occur here as well. Before an EMT, I would say, hey, it might be a good idea to tell your partner to get vitals while you're doing this. Now I'm telling you, you have to. So how this goes is, Alex and I are working together. I show up and I say, okay, I've got my chief complaint. I've gone through my pain and dyspnea inquiries. I'm now going to go into my ABCs. My partner, Ralph, would you please go ahead and get a full set of vital signs and start a 12 lead, right? Now, if you get a tough adjunct that says, tell me all the kind of vital signs you want, I would probably respond with something like, all of them is fine. I'm going to do my ABCs first, and then I'll get to the specifics. But I'm not going to let it slow me down checking if they're breathing or have a pulse, right? So we go through assigned vitals and 12 lead. This point for the 12 lead is, do you know that in the primary, we should be prioritizing these things? It's not, did you transmit and how did you do it? It's just literally, did you start delegating it, right? Yes, sir.
And so if let's say you're on a call and you delegate it,
Yep.
is verbalizing enough, or does the partner have to?
We will be
put it
physically
on?
doing 12 leads. It depends. Your partner in a practical can probably verbalize anything to save the effort, right? But if you end up doing it, you will definitely be graded on whether or not you did it right, kind of thing.
Did you guys do a lot of 12 leads in clinical?
I did a lot.
I did
I did a
two.
lot of 12
Two the whole time.
2 the whole time?
A ton. I did probably like 10,
I did like
15,
a
12
million
leads.
of them.
Yeah.
When we go into breathing, nothing's really changed there. Rate, rhythm, quality, circulation, rate, rhythm, quality, ask each one independently. Skin, color, temperature, condition, no big deal. We've got something new here, shock and sugar. It's still an S, so we'll count it. What this basically is that so many students were doing their ABCs and never even thinking like, wait a second, something's wrong here. This is my way of saying you need to, right here. Basically, if I'm tachypneic, tachycardic, bradypneic, bradycardic, pale, any ABCs that are out of whack, I want you to say, is there any chance that could be shock? And if it is, I start treatment right there, right now, right? The other part about the sugar is not always applicable. I mean, if I get a call for a guy that, put a gun in his mouth and then pulled the trigger or whatever, I don't want you to be like ABCs and then like, whoa, do not inspect his, do not do a physical assessment. It says sugar here. I'm like, okay, no, that's not where that may belong. The reason why it's there for shock and sugar is because there are more often than not times where it needs to go there and we don't see it. So I'm just saying, hey, think about it every time now. Landon?
Lung sounds.
Yeah.
Where are they now?
They appear essentially in your,
Supposed to assess?
I don't know, nowhere? Oh, there it is. It's an exposed excess in airway, mouth and then lungs.
Okay, I just want to make sure.
So shock and sugar, like, is that kind of where you want us to like think about like stroke assessment type too?
That's fair. Yeah, I think so. I hadn't considered that.
Like the equivalent of your field impression for shock. It's like, okay,
Yes, wow, well said. Yeah, field impression for shock. Yeah, I think that's fair.
and then
Now, admittedly, there are
Disability.
disability is mental status assessment. That's what they mean by disability. Now, admittedly, you can't write a scenario where everything's in the right place at every time. There are times where I get a patient with a chronic history of asthma who called today because they're dizzy, right? And they're like, I just am not sure if I have met the beginning of an asthma attack. Okay, what I'm not saying is I need to check their pupils, their mouth, and all this different stuff. No, lungs can exist way sooner, but it's just to kind of give a rough framework for where this stuff belongs. So expose and assess, this largely means, somebody's got a wrist pain, I pull back their, with their permission, I pull back their sleeve to check it out, right? I'm not inspecting the mouth of every patient, but if I am, I'm doing it at the beginning of a physical assessment for sure. I'm also not saying by listing all this stuff out that if somebody's dizzy because they think they might be having an asthma attack, that suddenly you're like, okay, I'm gonna check all 4 quadrants of the abdomen looking for non-pulsatile masses and stuff. And I'm like, right, this person doesn't need that, So all I mean to say is you'll kind of have to interpret when it's done. This is kind of written from the perspective of what if you did have to do every little thing? This is what I would look for. What I don't want you to say is like, oh, okay, I got a guy that, was ejected from his motorcycle and wasn't wearing a helmet. I'm going to check his neck. How's that look? And I'm like, no, that's not enough points. How's his trachea? Does he have JVD? And is there cervical spine? I probably won't ask you much more than that, but I'm going to make sure that you know that.
So if they have like a localized wrist injury,
Yep.
and you're not going to require us to check some of the other stuff, how would the points shake out?
Very differently.
There's way more.
So much
wrist
differently.
and-
So you're basically saying, like, I'll use this example. If it was just like a localized wrist injury, you're not expected to check, like, the points for checking the abdomen and stuff like that aren't going to be
well, isn't that
I'm
what we
expecting you to
switched
know
to
better.
risk assessment?
I'm expecting you to learn and know better.
right.
Now, I would assume it perhaps a focus assessment, but it goes back to our age-old statement, it depends, right? Can you ever imagine a scenario where a person that has wrist pain needs a 12 lead?
Yeah.
There's weakness
How?
in the arm.
It's the left. They have left arm pain, right?
I can
And
take
you
that.
can't detect a pulse in one side.
These are all decent answers. My point is it depends because you can kind of get there from a lot of different places. Why does his wrist hurt? Did he fall because he had a syncopal episode? Because he experienced a dysrhythmia secondary to an acute myocardial infarction? Because I can get there, you know? So it depends. So what this often means is that you should be getting points for a physical assessment, no doubt. And maybe you are only supposed to check one thing, but without checking everything, you don't find that thing.
So that kind
depends.
of had me think about like the 12 lead.
Mhm.
Would it be acceptable to like put them on a 3 lead and then? Well, I guess we can't interpret.
You're putting people on a 12 lead because you're sending it to a cardiologist. So a 3 lead does you nothing.
Okay.
It might because you're a clever duck, but it won't be ultimately what we're looking
I was
for.
thinking like you put them on a 3 lead to determine if they need a.
I would say this to medics will make this statement. They'll say, well, I'd walk in and I'd be like, look, you started a cardiac investigation, you should finish it. Why'd you put them on the monitor if you're not gonna put them on the 12 lead? Like you're asking good cardiac questions. Do a full investigation. Landon.
So now that there's no longer the option for a focused or rapid assessment.
There is. I am not trying to omit that.
Okay.
You are
That's-
still
that's what I
making,
make sure.
yeah.
So like say it was just like arm pain here. If I just did a focus assessment, would I still get all these points for doing?
Those points probably wouldn't exist.
Okay.
You know?
Because it's
Gonna be,
depend
it's gonna
situation.
be a different rubric for.
Yeah, I assume for each one conditions.
It depends on the situation. Yeah. I mean, don't.
I just want to make sure.
Even if it's focused, you're still gonna have to expose.
Expose,
and
palpate,
yeah.
feel.
And that wrist pain that's only usually worth legs of a injury 1 point is suddenly worth 6 because
Okay.
that's the entirety of the thing that you need to find. You know, you've got a dizzy diabetic patient or whatever, and I'm like, no, you don't get any points for the neck, you don't get any points for the head or whatever, but you get a ton of points for his left arm where the sensor is for his insulin pump. You know, so like it's gonna shake out a little differently.
Okay, I just want to make sure if it adapted or not. So.
Yeah, yep. This is a one-size-fits-all solution to a problem that cannot be one-size-fits-all.
Yeah, I like
The transport time is somewhat adjusted here, but you probably know that if you were in the last EMT cohort, that we're no longer like 12 minutes or a die. This is more of kind of a varying scale. It's working out. I think it's doing well. You might also notice that the specialty center and transport decision seems very heavily weighted. Most of these things are about 100% practical, and so 5 points on a specialty center is 5%. I don't know if that's going to be for every time, but consider this. I think this guy's having a heart attack. I gave him aspirin, which is a life-saving intervention. I gave him nitro, which is fantastic. And you know, I've given an 18 gauge IV so that way they can get all the things they need. And then I dropped him off at a Taco Bell.
He needs the PCI.
Like,
PCI
okay, all of that stuff is good, but if he doesn't go to the place where they can go in there and rotor-rooter out his clot, then you did nothing for him. So like you did an amazing job of work for a guy that's gonna die now in the Taco Bell parking lot.
Same with strokes.
Same with stroke, can be the same for significant trauma mechanisms and burns. It can be for all manner of things. So all I mean to say is that when you go into transport decision, you should be asking yourself 2 things. Is this the closest, most appropriate hospital, which is basically one thing, and then the second thing would be, what do I need to get specific consent here? You want to talk to people. Look, I want to take you to this trauma center because you're having the kind of trauma they're going to write stories about. You know, like I need to interact with my patient. With an adult, it's probably 1 point, but if it's a kid, it's now probably 5 points. Did you talk to the parents? Did you okay it with them?
So with that, or I know for the last scenario, you gave us like child center, B, whatever the other one was.
Yep.
Are we gonna actually use like real world
No.
hospitals now?
No, and in fact, it's one of the things where the other division, like where Mr. Simmons and I disagree. He kind of teaches from the lens of like, I want my students to know the places around, essentially. And I'm like, not all my students are going to work here. I don't care that they know what's around. They can figure that out later. What I care about assessing is, do you know why you're going there? Because the truth is Kennestone is the best place to go for almost everything we have. So anybody that just says Kennestone is going to get the points, but I don't know if they know why they're going there, which is why you're going to get dispatched to 2 fictitious hospitals, and you have to say, wait a second, what does Blue Hospital do and what does Red Hospital do? And I say, that's right.
Okay, and then are we gonna need to like activate people?
Do you mean like stroke alerts and stuff?
Alerts
My
or
opinion
sepsis?
is actually probably in the minority of paramedics. I say we don't activate anything. If I call into a hospital and I say, this is a stroke alert, his blood sugar is 113 with a perfect blood sugar and Cincinnati stroke scale negative, they're gonna say, no thank you, no stroke alert. So if I'm not overriding them, then what's the relevance of me calling for it? I also would say, like, look, I transmitted to hospital. I am activating the STEMI if that falls in the protocol. But if they don't see it, they're going to deactivate it. So no, I don't emphasize activation.
I only ask because one of my like medics had me do all like the radio reports.
Yeah.
And they asked me, we had this dude that like fell and hit his face, and they're like, "Is this like a trauma, like
Trauma,
alert?"
sure. Chip and
I
stuff.
was like,
Yeah, Coach
no.
Chip.
So
It's
they just asked. So I just want to make sure.
sometimes, yeah. I mean, I'm not going to enforce it here, but wherever you work, they may put the impetus. To be honest, when I started my career in the area I was in, there was much more authority on the medics to like wake surgeons and cardiologists up and come to the hospital. I think a lot of bad paramedicine has taken away some of that authority on our part. To kind of finish this up, just make sure you're looking through the interventions and see that you get a lot of points that don't involve literally doing the thing. Like applying a BVM not only comes with the seal, the question of is the rise and fall there, but also timing. Part of the reason for that is that people would come in and see this person is hypoventilatory, ventilate them immediately like you should, and that was amazing. Also, people would not know they needed ventilation, and it'd be 19 minutes and 50 seconds in, and they'd do a BVM and get the same points as the guy that walked into it. And I was like, okay, that can't happen. So we got all kinds of things in there. You're gonna see a strong emphasis of explanation. Don't just attack people with your interventions. Tell them what it is, why it's coming, and why you're doing it. Make sure essentially that you go through the rest of this simply because we're pressed for time here, so I'm gonna end. Signs and symptoms means to me that you are asking to the patient, hey, are there any signs and symptoms that have come up or that we haven't talked about yet? That's what that means to me.
A good clarification.
Additionally, the field impression, we are going to prompt you for that now. I think a lot of students knew what it was but didn't think to say it, and that sucks. I think a lot of students would say things we thought they knew what it was and they were just saying things. So we're going to make it a point to say, what is your field impression, even if you don't come up with it at that time?
Are you marked off points if you're incorrect on your field impression?
Yes.
Okay.
If you essentially give it, the points are awarded, they used to be awarded just if you did it. Essentially, we're starting now especially to say, okay, if you've been treating for chest pain protocol and then call this a diabetic emergency, you get no points. That's not correct.
Makes sense.
Additionally, make sure that you know that vital signs repeat timing means to me that if you end your scenario at 12 minutes and you checked 2 vital signs, that was appropriate because you timed them right. But if your transport time in Fantasyland is still 30 minutes, I need to hear you say that you are going to continue to assess vital signs every 5 minutes if they're unstable or 15 if they're stable. Also, make sure you're asking people as you stand them up. That's an intervention. How do you feel now? You sat them down. How do you feel now? I put you on a cannula. How do you feel now? I gave you aspirin and nitro. How do you feel now? Everything you do is reassessed. And in every scenario, ask, look, I came here and did a bunch of wild things to you. How do you feel now? Better or worse? Better? Great. Worse? I'm sorry. Let's slow down on some of that. And then lastly, that your primary changes is kind of a generic statement like, hey, anything change my primary at all? Anything with my ABCs, skin color? I'm okay with you kind of summarizing the entirety of the primary in one fell swoop, but you got to make sure to do it. Also noting as far as critical criteria, I don't often penalize people for, I don't say, basically I attribute points according to the things and the value that they're worth. So if BVM is very important, you don't get a critical criteria for not doing it. It's just worth 15% of the grade for doing it. Yeah. Critical criteria walks in with you coming in and just being like, oh, beans, and it's a swear word. And I'm like, you can't do that. Or you're like, oh, I'm gonna go ahead and give epi to this person. And I'm like, that is in no way indicated. I don't have a point system for doing wild things like that, and that would be critical criteria and 10% off.
And
Landon?
then going too long.
No?
Oh, no, you're right. 0 points. Transport.
So for reassessment of interventions, if I'm doing that consistently throughout my assessment, like I put them on nasal cannula, I check back, hey, how
And you should.
does that
It counts.
count?
You don't need to wait to the end and then say, I'm going to talk about all my stuff. In fact, ideally, you are checking it every once in a while.
I just want to make sure.
Yeah. And so that's our patient assessment summary in a nutshell.
Nice, yeah.